All right, everyone, might make a start. Hello and good morning. My name is Apu and I'm the Injury Prevention Officer here at Injury Matters. And I'm so excited to be facilitating this webinar today, which will be looking at different forms of violence and explore ways we can advocate for a safer WA by addressing key violence prevention strategies to make our environment safer, a safer place for everyone. I'd like to thank everyone for tuning in today and taking the time out of your busy schedules to build your knowledge and awareness around different forms of violence in WA. Today, I'm facilitating this webinar from Whadjuk Noongar land. So I'd like to acknowledge the Whadjuk Noongar people who are the traditional custodians of the land on which I am facilitating this webinar today. And I want to also pay my respects to their elders, past and present, as well as the leaders emerging. Australia always was and always will be Aboriginal land. I'd love to know where everyone else is tuning in from today, so please use the chat box to acknowledge the traditional custodians of the land you are tuning in from. Before we start, I wanted to go over a few housekeeping points. Can you just make sure that if you're an attendee, your microphone is muted? This will allow everyone to hear the presenters clearly. We'd also love to hear your questions. So we strongly encourage you to please send them through the Q&A box, and we'll go through them at the end of all of the presentations. If you have more than one person in the room with you listening in to today's webinar, we'd appreciate it if you could please send us a quick private message via the chat tab to let us know how many people are tuning in with you. Also, if you face any technical issues throughout the webinar, just let us know. We'll do our best to help you. And also, this webinar is recorded. So a bit about us at Injury Matters. We are for safer people and places. Injury Matters aims to prevent and reduce the impact of injury within the Western Australian community. And we do this through advocating and providing education for injury prevention, as well as providing support for people who have been impacted by injury. Today's webinar is brought to you through the No Injury program, which is supported by the WA Department of Health. No Injury is a statewide program which aims to enhance the capacity of injury prevention and safety promotion practitioners to deliver quality injury prevention activities. Via the No Injury program, we provide training events, resources, and networking opportunities to support injury prevention across the sector. So what is the definition of violence? For today, violence is the intentional use of physical force or power, threatened or actual, against oneself, another person, or against a group or community that either results in or has a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. In Western Australia, between 2015 and 2019, there were 17,134 hospitalisations due to assault. 58.6% of hospitalisations for assault were male. And people aged 25 to 44 had the highest incidence of hospitalisations due to assault. Today, I'd like to focus on three different forms of violence: family and domestic violence, elder abuse, and a great example of how violence was addressed in a smoking cessation and violence prevention pilot program that was trialled at Royal Perth Hospital. So today we'll be hearing from Lisa Jones from Lifeline WA on family and domestic violence, Louise Foster from Advocare on elder abuse, as well as Holly Scott and Rachel Wixon from East Metro Health Service on the Royal Perth Hospital Violence Prevention Pilot Program. I'd like to start off by handing over to Lisa Jones from Lifeline WA.
Thanks very much. Just bear with me for a moment while I get the slides on.
No worries.
Okay, is that sharing okay? Great, all right. Okay, I would like to acknowledge the traditional custodians of country throughout Western Australia, wherever you're joining us from. And for me today, that's the Whadjuk people of the Noongar Nation. We pay our respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So my name's Lisa Jones and I've had a number of roles at Lifeline WA over the years, including being a crisis supporter for our 13 11 14 crisis line. I've also been very involved in the delivery of our DV Alert domestic and family violence training program around WA, which I'll speak to more further into the presentation. I'd like to acknowledge the many ways that family and domestic violence impacts on individuals and communities and those with a lived or living experience joining this session today. When we're talking about domestic violence, a reminder to practice good self-care for yourselves during and after the session and to reach out to supports and resources should anything discussed impact on you. Okay, so in our time together today, I'm going to be speaking about some key understandings about family and domestic violence. I'll talk about a few statistics of FDV in Western Australia, some support services available, where to go for further support, and I'll talk about the training that we offer. So what is family and domestic violence? Well, there are many definitions, but one is an unequal distribution of power, whereby one person has control over the other and uses violence and abuse to maintain that level of control. It's a serious violation of human rights. The word violence may be interpreted as physical, but violence takes many forms. Let's explore this with an example. So when Kelly and Trent first started seeing each other, things were good. Trent was very attentive and in regular contact. Gradually, he became more forceful. He insisted that Kelly should give up her weekend shifts at work to spend more time with him, which cut her pay substantially. So within a relationship, people might make equitable decisions about financial matters, but in this case, we're seeing that forcefulness, that insisting, which could disadvantage Kelly financially and perhaps make her more dependent in the relationship as well. So financial abuse. After they moved in together, Trent's attentiveness became more overt jealousy. He pressured Kelly to stop seeing and speaking with any male friends or colleagues. And if she pushed back, he told her she was stupid and should be more grateful to have someone who cared about her that much. So here we see some social abuse, taking decisions away from the person on who they should be friends with or who they should have social connections with. And then emotional and psychological abuse. So name calling, undermining someone's self-esteem and things of that nature. Then he started checking her phone. One day when he found a text he didn't like, he threw her phone at the wall, smashing it. He later apologized and came home with a new phone. When he set it up, he activated software that would allow him to see her GPS location, and Kelly was unaware of this. So here we see physical abuse. So sometimes people may think of hitting or punching and pushing as physical abuse, but also things like, breaking and damaging property or throwing things towards someone even without hitting them are all forms of physical intimidation and violence. And then we also see technology facilitated abuse here, where he's using GPS tracking to stalk her as well, to track her behaviours and where she goes and perhaps who she spends her time with. So we see the types of violence and abuse are usually interconnected. For example, it may begin with social abuse, which isolates the person away from their family and friends and support networks. And as other forms of abuse increase, the person doesn't have this access to perhaps bounce things off their trusted people in their life. Hey, this happened, it didn't feel right. I'm not sure I'm feeling comfortable with this. And the person using violence uses a range of strategies to maintain that power and control over the other person. Another word associated with family and domestic violence is coercive control. So here's one definition. It describes a tactical pattern of behaviours that are designed by the perpetrator to control, intimidate, create dependency, and render the victim powerless. The perpetrator will use a range of tactics to leverage the emotional investment the victim has in the relationship to introduce rules and regulations that only apply to them, as well as penalties for non-compliance. So Jess Hill, an Australian investigative journalist, has reported exclusively on domestic abuse since 2014. And something of particular interest to her was how the behaviours used in coercive control came up in several contexts, such as prisoner of war camps and cults. These tactics are used because they are deeply effective in overriding the person's autonomy and perspective. And in cases of family and domestic violence, these very compelling behaviours are coming from someone close, from a loved one, which can make them all the more powerful. So who experiences FDV? Well, men, women, and gender diverse individuals can experience it and can perpetrate it. Violence and abuse are never okay, and all victims of family and domestic violence deserve a compassionate response. We do see that men are statistically more likely to perpetrate family and domestic violence. And research also tells us that women are more likely than men to experience fear, to experience more frequent, prolonged, and extreme violence, to suffer physical harm and injury, and to be the victims of intimate partner homicide. We acknowledge the language when discussing FDV is very gendered, and this is done so because it's a deeply gendered issue rooted in structural inequalities. But we do acknowledge that gender diverse people's experiences of violence aren't captured in gendered terms. So some facts about family and domestic violence in WA. 1 in 5 Western Australian women reported experiencing partner violence since the age of 15. Every 10 minutes, WA police respond to an episode of FDV. 1 in 3 sexual assault offences in WA were related to family and domestic violence. 61% of all recorded assaults in WA were related to FDV. The North Metro Health Service looked at assault by an intimate partner and found that 93% of people they treated for this were women. And 71% of all female murder victims were experiencing FDV before their murder. So look, we see from these statistics that FDV is very prevalent in our communities, and it presents very real danger of injury and in some tragic circumstances, death. So what did we see happen as a consequence of COVID? Well, in May 2020, the Australian Institute of Criminology surveyed 15,000 women, so a very large study, aged 18 and over. They were asked about their experiences of FDV since February 2020, when the impacts of COVID were first beginning to appear in Australia. When asked if they'd experienced violence and abuse from a current or former partner in the 3 months prior, 4.6% experienced physical or sexual violence, 5.5% coercive control, and 11.6% some form of emotionally abusive behaviour. And when looking at women who were in a cohabitating relationship, these figures rise significantly. So 8.2% physical or sexual violence, over 11% coercive control, and over 22% some form of emotional abuse. Women commonly reported experiencing both coercive control and physical or sexual violence. Of those who reported experiencing any of these things, over half experienced both together. So what we see is that coercive control and physical or sexual violence often go hand in hand. And of those who were experiencing violence and abuse, more than half said that the violence increased in frequency or severity along with the pandemic. The study also found that the following specific populations were more likely to experience domestic violence. So Aboriginal and Torres Strait Islander women, people with a long-term health condition, experiencing high levels of financial stress, pregnant women, and young people, in particular, women between the ages of 18 and 24. So these are some quotes from people subjected to family and domestic violence, talking about some of the things that made it difficult for them to seek support. So not realizing what abuse is taking place until you're further down the line of the relationship, feeling that it's you, blaming yourself for doing something wrong, or not knowing who to trust or who to talk to and locking up everything inside. A summary of other common barriers and challenges for people experiencing violence is fear of increased risk of violence, fear of removal of children, of not being believed, stigma and shame, any social repercussions, and also taking on self-blame for the abuse. One question that often gets asked around family and domestic violence is, why doesn't the person just leave? The onus is often on the person experiencing violence to leave the relationship rather than on the responsibility for the person using violence to change their behaviour and seek appropriate support to do so. We know that leaving an abusive or violent relationship can be the most dangerous time. The violence can continue or can escalate after the person leaves the relationship. So we want to shift the focus on the abusive behaviour, not on women's choices. So what can we do if we suspect someone may be experiencing family and domestic violence? Well, we can ask them about it. They may not be ready to talk, and we need to respect that, but showing your concern can be the first step towards increasing their safety. One example of how to do this is to ask, has anyone at home or has your partner ever made you feel unsafe or threatened? And if someone tells us that yes, something like this might be happening to them, we want to listen and believe them without judging. So thank you for telling me. It's understandable that you're feeling scared considering your partner's behaviours. We want to affirm the person's rights. So saying things like, everybody has the right to feel safe at home, or no one should be treated that way. And we also want to communicate through our words and actions that the only person responsible for the violence is the person who's using the violence. So we can say something like, you're not to blame. Abuse is common and happens in all kinds of relationships. Safety planning aims to increase the safety of the person and any children while they're experiencing violence. This slide summarises what we know about high risk factors for serious harm and death. It isn't an exclusive list, but these factors highlight where it is especially important that safety planning is undertaken. And the best way to make a safety plan is with a support service, like 1-800-RESPECT is a good place to start. So we can see here that some of the high risk factors are separation, actual or pending, which we've already spoken to, pregnancy and new birth, which we saw in the COVID research as well. And there's also some things in here around behaviours, so stalking behaviours, coercive control, if the person is making threats, and if there's some situational things happening as well, like going through court proceedings or sorting out parenting arrangements. And you can see some further risk factors here as well. So where can we go to for support? Well, anyone can contact 1-800-RESPECT for advice. And this can be if you think you know someone personally or professionally who may be experiencing violence, you can contact them as well to find out some options for helping someone. And there are many services available that can support people subjected to violence. Rather than listing them all here, we wanted to give you a couple of good service directories that you can use to look up what's available in your area. So the Centre for Women's Safety and Wellbeing have a comprehensive list searchable by location here. And then Ask Izzy isn't specific to FDV. It has a range of different categories of types of supports, but it works really well on mobile phones. So it's good to have one to have in the back of your pocket if you ever need to find something on the go. So we've got those web addresses there and also QR codes that should take you directly to those links as well. Okay, so I'm going to talk a little bit now to our DV alert training. And the core reason for this is that it recognises that the first person that someone connects with may not be a specialist domestic and family violence worker. It could be a number of other different roles that they interact with. So people in the community sector, like support workers, health and allied health, education, childcare, and really anyone in a role which is a frontline capacity providing direct support to the community. And this can be through paid or volunteer work or as a student who is currently on a placement. Now, the program is fully funded by the Commonwealth Government through the Department of Social Services. And what that means is that there is no cost for eligible participants to attend. It is fully funded, those positions. And it's part of a national plan to reduce violence against women and their children. On completion, people receive a nationally accredited unit of competency as well. So it is an accredited course. The training is based around a recognised respond and refer model. It's also underpinned by assessing risk, planning for safety, and practicing self-care. There are a few different streams of training available. So it starts with our awareness sessions. So there's a 2-hour and a 1-day DV Aware, which is for any interested adult. And that really covers those foundations, a couple of the things we've talked about today. What is domestic and family violence? What are some of the patterns that we see, and what can people do to help? Brothers Standing Tall is a session specifically for Aboriginal or Torres Strait Islander men, which is about standing up in community and talking together on what can be done to prevent violence. And then our 2-day courses, so 2-day face-to-face, or it's 3 days virtual, and there's also fully online self-directed e-learning options as well. These are our courses, accredited courses for community frontline workers. General DV Alert is our core product, and then there's also a range of other 2-day courses which cover exactly the same content, but they are co-facilitated with one of our partner trainers, and they focus through the lens of providing support to those communities. Once people have done one of the accredited courses, they can also go on to do a 1-day add-on. So complex forms of violence goes into things like trafficking, dowry abuse, working with interpreters, and then we've also got men who use violence. So we deliver around WA, so regional and remote, as well as Perth Metro. To the left are some of the locations that we've already delivered this financial year, and to the right are some sessions coming up that we do have spaces available. And as mentioned, they're fully funded. Anyone can attend the 2-hour, and then frontline community workers for the other courses there. The best place to find out what's coming up and to enrol is to visit the DV Alert website. So that's dvalert.org.au to view upcoming workshops and get your space at one. So thank you very much for inviting us to speak with you all today. I hope that there has been something useful that you could take away. If you do have further questions or want to get in contact with us, here's the contact details for our education and training team. And also a reminder that Lifeline is here for everyone, anyone experiencing a crisis, which is any time that your current situation is overwhelming your capacity to cope. And that can be all of us at times. So we're here via phone, 13 11 14, text message or online chat, and all of those supports are available 24/7. Thanks very much.
Thank you so much, Lisa. That was a great presentation. Now I'll move on to Louise Foster from Advocare, who is the Chief Executive Officer, and we'll be talking about elder abuse in older adults.
Thanks, Abu. And apologies, I have a very squeaky chair, so hopefully it doesn't come through to the microphone too much, but try not to breathe too much. So thanks for having us. We're going to talk about elder abuse. I'm going to talk about elder abuse. around the signs, control and coercion, try and tailor it for the audience with today's topic. I'm not moving forward. Is that moving forward, Evan?
Yep, I can see your second slide now.
Great, awesome. So just a bit about Advocare. We've been around for 25 years. We're part of a national group doing similar work. So what we do is inform service delivery and influence practice, improve our services and try and create better outcomes for older people. So that's people over 65 or over 55 if they're Aboriginal or Torres Strait Islander. But we are quite a small team and quite clear on what we do. We don't deliver mediation, provide legal advice or undertake case management, and we do lots of referrals to partner organisations where we don't cover that kind of work. So today I'll just give a bit of an overview around elder abuse and trends and shifts and signs, how to respond, and where to find some other support and information services. So with this quote, I just think it's really important to kind of know that we've got professional obligations, but also societal responsibilities to human beings. So really the abuse of older people is everyone's business. So this is the World Health Organization definition of elder abuse. There's a single or repeated act or lack of appropriate action occurring within any relationship where there's an expectation of trust, which causes harm or distress to an older person. And it can constitute a violation of human rights and include physical, sexual, psychological and emotional abuse, financial and material abuse, abandonment, neglect and serious loss of dignity and respect. And I think it's very underreported, probably similar to other types of violence, but it's anticipated that 1 in 20 older people might be experiencing abuse, and we certainly aren't seeing that coming forward, but there's definitely a kind of dark cloak of abuse that's happening and not reported. So at Advocare, in the 1920 financial year, we received 1,347 calls to our elder abuse helpline, which probably constitutes for under 10% of work we do. A lot of our work is around advocacy, so people are having issues or concerns in their life generally, and particularly if they're receiving aged care services. But the elder abuse helpline is kind of triage and people to make a call if they're generally if they're unsure actually whether abuse is happening. We find that if it's quite categorical and clear, and particularly if it's physically violent, we don't get as many calls. We believe that they might go through to police or other service providers. A lot of calls we receive are people kind of questioning, is this an issue? It's often insidious and quite confusing, and like some of the quotes that Lisa had in the Lifeline presentation, I think individuals think that they might be the cause and it's therefore, or they're overreacting. So I'll just give you a bit of an overview of the case study, which has been de-identified, but Gemma's in her early 90s and lives at home with one of her 4 adult children. And that's the youngest son, and they've lived together for over a decade, and he's in his 50s. That son's got a problematic relationship with alcohol, refuses to work or contribute financially, and demands money from Gemma on a regular basis. He takes Gemma's car and banking card without permission and sometimes doesn't return for days. Gemma stated that he can scream and swear at her and demands that she goes into her bedroom and denies her access to the lounge room and watching TV. And Gemma feels quite scared, feels that the threats there are that there will be some harm if she doesn't give in to his demands. So Gemma's now worried about her physical safety to the point of escalation where the son can get quite violent. So we can see in Gemma's story that there's psychological, physical, financial and social abuse. So this is often what we see as well when we have phone calls around abuse. Often it's more than one type of abuse that's happening. I think for there to be financial abuse, often there needs to be a level of psychological abuse to kind of create that control for the financial abuse to happen. So, as I said, we've been around 25 years, celebrated 25 years last year, and we've seen some shifts over time. So when Advocare started as a service as part of Anglicare before 1996, and then became independent, people really didn't talk about elder abuse, didn't really know an awful lot about it, and there were very few referral pathways for someone experiencing it. So it was very much the early days. And there was a speak out survey for some of these early years. And if anyone's interested in any of this, we can help you get links. The next kind of decade really saw a little bit more awareness. There was this research around community attitudes towards elder abuse. And we're seeing just under 5,000 calls in one of those financial years. And then through to the most recent decade, 20,000, so like a fourfold increase on that decade. And also the first ever national elder abuse prevalence survey. Unfortunately, though, with the research is so few and far between and very different models that it's quite hard to get consistent views on elder abuse prevalence. So it's still pretty not very well understood. So responding, as I said at the beginning, we've really got often professional responsibilities. We may have mandatory reporting as part of the sector we work in. So in residential aged care facilities, there is mandatory reporting. In home care, there isn't. So there are varying different professional responsibilities, but we also have a societal responsibility if we see something that's happening. I definitely recommend people accessing the elder abuse protocol. This is something that was put together in 2017, published in 2018, and we're looking to review that soon. And it was, you can't quite see it on the left there, but there are a number of contributors, and a lot of those contributors are also part of the Alliance for the Prevention of Elder Abuse, APIA, which I'll give you a little bit more information on. Advocare chairs that cross-sector group, which includes community service providers as well as Surrey Police and Public Trustee, Office of the Public Advocate. So this is a really helpful document, and we'll update that probably this year just to make sure everything's current in how to respond to elder abuse. So some of the prevention strategies is ensuring that older people have an awareness of the type of documentation and agreements they can have in place. So enduring power of attorney, which is around money decisions, financial decisions. Enduring power of guardianship, which is around health and lifestyle decisions. Sometimes having those different people can be helpful, so there's not too much power with one potentially, say, adult child, which is where we do see some issues. And advanced health directives to support that enduring power of guardianship to help people understand what wishes are. Having a will, and not just having a will, but having it up to date, reviewed, and know where the copies are, and anyone who is an executor also knowing where those copies are. Family agreements. A lot of the calls that we receive are around verbal family agreements, and particularly around tenure and the house. So we see just repeatedly a senior person who potentially has moved in with adult children, either into the main house or into a granny flat, and may have sold the senior may have sold their property and invested all or part of their money into granny flat or into a renovation or the adult child's house. But these agreements are often verbal, and there's an awful lot of trust there. And when there's a relationship breakdown, and sometimes it's with blood member of the family, sometimes it's partner, so an in-law, what we see is people potentially becoming homeless or having a risk of homelessness, cut off from their possessions and cut off potentially from family members. It can get extremely fraught, and having very clear and written family agreements when there's changes of tenure is really important. Staying connected, I think we heard that from the Lifeline presentation as well. When people are essentially cut off from others, they're more at risk. So for us, it's very much about ensuring that family, friends, neighbours and other community members keep those connections going with older people. And one of the programs we have is a community visitor scheme, which is Commonwealth funded, and volunteers go and visit older people either in their homes or in a residential aged care facility. They need to be receiving services to access this service. But it's really about having just a member of the community popping in to see that person once a week or a fortnight, and having that extra connection, that extra set of eyes and ears really reduces people's risk of being a victim of elder abuse. And again, accessing aged care services generally. So I mentioned about APA, the Alliance for the Prevention of Elder Abuse. So some of the members are noted below, but what's really helpful about this is very different perspectives. For me, I find having WA Police very useful as part of this group. And some of the things that we've been looking at as a alliance is what we can do after identifying areas of abuse. So in New South Wales and South Australia, they have safeguarding laws. Both states work a little bit differently, but similar to some of the action that can be taken around family and domestic violence. And those safeguarding laws mean that elder abuse reports can be investigated and prosecuted. In WA, unless there's criminal activity, there's sometimes can be, a dead end in what we can do to support people who are experiencing elder abuse. Which is very hard for people working in the sector as well, that real vicarious trauma when someone's in a very difficult situation and there's sometimes not a lot of action that can be taken, particularly with those really insidious forms of elder abuse. Another initiative we're working on this year is to look at media guidelines. So we sometimes see elder abuse reported when an older person is just a victim of any kind of violence or crime. For example, if someone's attacked in a shopping centre and they're over 65, we'll sometimes see media talking about elder abuse. That really doesn't meet the definition and actually dilutes the impact of messaging around what elder abuse is. That's a few things that we're doing around that. And coming up on the 15th of June is World Elder Abuse Awareness Day. I don't know if any of the participants have ever seen the Purple Road, which is a huge length of purple crocheted squares, and the Northern Suburbs Legal Resource Centre started that, and it's really a beautiful movement and a way of sharing the message around awareness of elder abuse and hopefully reducing prevalence of elder abuse. So at the Care, we have a couple of events happening, and particularly the webinar on Thursday, the 16th of June, has got a service provider focus. So if anybody is interested, reach out, or we have these on our website. And we're also in carrying up and manager shopping centres to try and talk to the community, raising awareness about elder abuse. And I guess just as I wrap up, really, I'm wanting to just note that the definition of sexual abuse is just much broader than we might think, and we find that can be a kind of socially unacceptable form of abuse to talk about often, and can be seen as very black and white. At one end of the spectrum being quite definitively someone abused or raped, for example. But really that it's all about boundaries and comfort, and if any individual is uncomfortable with any verbal or physical kind of interaction, it can constitute as that. So I think that's probably still a lot of stigma around that, and we want to raise a bit more awareness. A couple of our staff have been doing a national course on looking at sexual forms of violence, particularly in residential aged care. And if anyone's interested in any more of that, feel free to reach out. And that's me. Thanks, everyone, and Apu.
Thank you so much, Louise. That was a great presentation. Lots of useful resources as well. So thank you. Just a reminder that if you have any questions, just please pop them in the Q&A tab and we'll take questions at the end. So yeah, I'll handball it to Holly Scott and Rachel Wixon, who are from the East Metro Health Service, and we'll be talking about the Royal Perth Hospital Violence Prevention and Smoking Cessation Pilot Project.
Thank you. I'll just share the screen. Can everybody see?
Yep, we can see your
Yes.
slides.
Okay, great. So thank you for inviting us to share our work today. I'm Rachel Wixon and I will be presenting with my colleague Holly Scott on the State Major Trauma Unit Smoke-Free Pilot. Thank you for the acknowledgement to country at the start of our session. We are grateful for this opportunity to speak with you from the Whadjuk Noongar Budja and acknowledge elders past and present and emerging. So nicotine withdrawal is a condition that occurs upon abrupt discontinuation or decrease in intake of nicotine by nicotine-dependent individuals. Withdrawals can start within 1 hour after someone has smoked their last cigarette and can make an individual very uncomfortable. Nicotine withdrawal psychological symptoms such as irritability, restlessness, agitation, frustration, and anger can increase risk of violence to self or others, including staff. There are a number of factors why people become violent in a smoke-free space due to nicotine withdrawal, and this project also identified broader system issues which contribute, which Holly will discuss shortly. Our East Metro Health Service data shows that smoking-related violence and aggression towards staff is a significant issue. This is an issue in all hospitals, and particularly in areas such as the emergency department, acute medical unit, the state major trauma unit, and mental health wards. So the evidence shows that a systematic approach from the moment a patient enters the system to the moment they are discharged at hospital is the most effective and extremely important. The ABCD approach is a model which offers support and treatment throughout the patient's stay in hospital and on discharge. This is best practice, and support and treatment are essential in a smoke-free hospital system from an ethical perspective. So the ask component asks a patient if they smoke cigarettes or e-cigarettes and records the response. The brief advice assesses the patient's nicotine dependency using the Heaviness of Smoking Index by asking time to first cigarette and number of cigarettes smoked per day. Brief advice includes nicotine replacement therapy, education on the use of nicotine replacement therapy products, resources, and referral to behavioural interventions. Communication at discharge records in the system on the patient's discharge summary, nicotine replacement therapy and other supports offered or received, and the re-offer of resources and referrals as appropriate. This is the model that we use for the State Major Trauma Unit pilot and that we continue to use for the service-wide smoke-free project across East Metro Health Service. The health promotion team looked to Alfred Health in Victoria and other health service providers and at our colleagues at Armidale Hospital who had piloted the model at a long stay ward. The State Major Trauma Unit presented an opportunity to trial a suite of strategies within a very fast-paced environment with a complex cohort of patients.
Great, thank you, Rachel. So the pilot with the State Major Trauma Unit was initiated in response to 4 key issues that the unit themselves identified in becoming smoke-free. And so you can imagine that with a cohort of complex patients, smoking adds a complexity factor again. So the trauma unit identified that firstly, Royal Perth did not at the time have access to a full range of nicotine replacement therapy products. Secondly, Royal Perth did not practice nurse-initiated nicotine replacement therapy, which was leading to a delay in the provision of nicotine replacement therapy, and this means patients are in withdrawal for longer. So nurse-initiated nicotine replacement, or NRT, means it's listed as a medication that nurses can start for a patient rather than needing to wait for when a doctor is available to see them. And that means reducing the amount of time that a patient would feel uncomfortable and irritable. So a lot of these strategies, as Rachel mentioned in the model, are around creating more comfort and less agitation for the patient. Thirdly, patients were annoyed or angered if some were allowed or rather enabled by staff to go outside to smoke and others were not. So inconsistency of this practice was a significant cause of aggression towards staff. If one nurse allowed a patient, took them off the ward, and then the next shift the nurse wasn't so keen, it created an inconsistency. Strong trauma recommendation was that staff all comply with the policy, which at the time was that they were actually not meant to escort patients off the ward. And the trauma ward was really keen for this to be 100% consistent across not only their ward, but the whole hospital, and also felt strongly that a wider community campaign was needed so that patients and visitors knew what to expect better when they entered the hospital system. The last issue they identified was that staff who smoke undermine the policy. They undermine the importance, or they may return to the ward smelling like smoke, and that was unhelpful for patients. Some of the broader system issues are, for example, often when patients come into hospital through the emergency department, they are most likely already in nicotine withdrawal. So the waiting time in emergency or arriving, they're already feeling irritated or some withdrawal symptoms. Also, involuntary mental health patients entering through the emergency department may need to wait, and that wait can be up to 100 hours for a mental health bed. Thanks, Rach. So this slide really shows our response to the issues. So we created a suite of resources and a multidisciplinary steering group. So the key success factors were the partnership between the health promotion team and the State Major Trauma Unit, the strong leadership from Dr. Sadaka Rao, which was key on the ward, and also the steering group, which the different disciplines and the skill set and the commitment really made this project work. The Royal Perth Bentley Group Clinical Practice Standard is the guideline for clinicians on the practices to support patients who smoke. So the pilot had key performance indicator of 85% of staff being trained prior to starting implementation of the Clinical Practice Standard, and a range of resources as listed here were developed. Dr. Kelly Ridley was very generous in helping create these resources. She was a mental health doctor who was really supportive in creating those resources. COVID also added a complicating factor. So this pilot was started in February 2020, and the implementation was rolled out in May 2020. So COVID really did factor at this time, and it did limit our access to the ward for training and evaluation. The initial plan was to trial the changes to the clinical practice standards in the trauma ward. However, due to COVID, the need was identified for a quick rollout across all wards of East Metro Health Service. This included a 15-minute briefing to each ward, but not the additional support strategies and level of training that the trauma ward received. So that part of this project was actually updating those clinical practice standards to be best practice. And it was great that they were rolled out early, but what Rachel will talk more about how important the extra support was in making a difference.
So one component of evaluation was measuring smoking-related violence and aggression towards staff. And this was measured through code blacks and aggression incidents. A hospital code black is called when there is a personal threat to self or to others. Aggression incidents are recorded in the system when a violent incident has occurred. However, a code black is not required, meaning security was not called. We looked at two forms of data, Sentry and Choir. So Sentry data are entries made by security when they have attended a code black. So it reflects the amount of code blacks recorded by security, but not by staff. It doesn't reflect aggression incidents reported by staff whereby a co-black was not caught, as mentioned. This may be as the incident was de-escalated by the staff members. Choir data are entries made by staff for co-blacks and aggression incidents. It's a bit of a mouthful. Staff underreport co-blacks for numerous reasons. Aggression incidents don't always require co-black to be caught, and as mentioned, that could be because staff are trained in de-escalation. However, they still reflect aggression and violence towards staff. And when we reviewed all the comments and analysed each entry for the pilot, pre and post, we identified that they were serious aggression incidents. So during the pilot, there was an 89% reduction in smoking-related co-blacks compared to the year prior to the pilot, as the graph shows. Overall, there was an 84% reduction in choir entries, which includes co-blacks and aggression incidents reported by staff. So we used a comparison ward to show that firstly show that COVID did not affect the overall co-black numbers. And as shown in table 1, you can see that the co-blacks remain consistent from year to year in both those wards, in the trauma ward and the comparison ward. And table 2 shows comparison of smoking related co-blacks in the trauma ward where we implemented the pilot. So having that suite of strategies embedded and that extra support, compared to a ward which had very limited support, but still had access to the new clinical practice standard, as Holly mentioned earlier. It's important to note the proportion of patients who smoked in the trauma ward in 2020 was 40%, and in the comparison ward was 24%. So what this means is we were dealing with a cohort of patients with a higher smoking rate. And we acknowledge there are other differences in the wards, such as the length of stay and the specific cohort of patients. However, this provides an indication for comparison.
So when we look at this graph, what we're looking at is our patient file audits. So we went through the process of looking at how the smoking management was documented. So what we can see here in the ask column is that generally patients are getting asked whether they smoke, their smoking status, and that is getting recorded. However, when we look at the second column, we're looking at the heaviness of smoking index. So are patients being assessed for their level of dependency and whether they need nicotine replacement therapy? At the start, that was very low. So you can see that that's not being recorded in the first, the pre, it was very low, and that steadily increases as we implement. However, at a certain point, it was early in the pilot, we realised that we weren't getting the assessment that we were really expecting because we had a high level of training. And if it was happening, it just wasn't being documented. So that purple column at 63% is where the trauma unit made the simple change of putting the nicotine replacement therapy chart in every patient file. So they didn't have to run out of the room to get the chart. It was in the file. A simple change. However, you can see that it made a difference. The nicotine replacement therapy offered increased steadily over the pilot period. So these are 5 points across the pilot pre, during and post. So it was a steady increase. The brief advice also increased. However, what we note with the trauma ward is that the cohort of patients is generally more, they're staying for a shorter period of time generally. However, they are also either more complex or the injury is more serious. So managing smoking is really about making the patient comfortable and addressing a longer term brief advice conversation. Is more likely going to happen either on another ward or on discharge. So that does explain why that's a little bit lower. The communication at discharge didn't increase greatly. However, that's a system issue that we're looking to address in how we record that information. And so some of those challenges is around how we can share a common definition of brief advice and who's responsible and how we document that. So they're further challenges that Rachel's team is addressing. Here you can see some that we completed a survey prior to starting the pilot. And really the key stat there that we'd like to highlight is that at the beginning of the pilot, overall, there was 82% of staff who experienced verbal or physical aggression at work from a patient, specifically related to smoking. However, after putting in place the pilot strategies, we captured quotes of positive feedback from members of the steering group and also trauma patients. And overall, there was a clear direction from management, and the consistency in the approach was very much appreciated. So now this means that the management of nicotine dependency is much more consistent and routine practice. So you can see some of those positive comments that both staff and patients are less stressed and more comfortable with the way smoking is being managed on the ward.
So these are the reported high-level recommendations from the pilot. I won't go into them in too much detail, but overall for the wider Royal Perth Bentley Group and East Metro Health Service, this is to ensure a systematic approach to manage nicotine dependency in patients who smoke. And this is particularly important given the recent changes to the statewide policy, removing the exemption which allowed involuntary mental health inpatients to smoke. So the final report, the closure report of the pilot was endorsed by our area executive group in August last year, and the significant reduction in violence and aggression towards staff really contributed to that. This was a vital step as we understand the importance of influence from executive through towards staff. So what has happened since August last year? As mentioned, at the time the pilot recommendations and support to roll out these across all our hospitals was endorsed by our area executive group, the new WA state-free policy was released, and one of the major changes included the removal of the exemption allowing involuntary patients to smoke, which all health service providers need to be compliant by July 1st this year. So this has a huge impact on all areas of the hospital, but especially mental health. So what has emerged is a service-wide project called the East Metro Smoke-Free Project, which aims to improve clinical practice that supports the implementation and compliance with the WA Smoke-Free Project. And we, employing and expanding on the strategies utilised from the State Major Trauma Unit pilot. So this is being rolled out now across priority wards. So our emergency department, mental health and acute medical unit across the 3 hospitals, Royal Perth Hospital, Bentley and Armidale. In September, October last year, we received funding to establish a new multidisciplinary East Metro smoke-free team and began recruitment as well as progressing the planning phase of the project. So in January this year, the team started, and with relevant clinicians and staff across East Metro, we collaborate to progress a sustainable and systematic adoption of best practice standards across the priority areas that I mentioned. And this includes establishing governance and staff commitment, communication, staff education, training and support, implementing workable systems in clinical practice, ensuring a healthy workplace, so having a staff nicotine replacement therapy program, developing and installing new smoke-free signs across all our hospitals, local policy changes and monitoring and evaluation. And a key component of that will be monitoring the smoking-related violence and aggression towards staff. So we are 4.5 months into the project, and despite COVID, we have made significant progress. And that wraps up our presentation for today. Thank you.
Thank you so much,
to say that
Rachel.
Oh, I was just going to say also, we understand that the broader, the population around the community approach. So we actually do have some education programs that we go out into the community as well. And some of those programs are targeted and tailored to support Aboriginal community members. So if anyone would like more information about those programs, the Yarning It Up, Don't Smoke It Up, or Muditchwer and Coolunga for younger people, then please get in touch with me.
Thank you, guys. That was a great presentation. Lots of info there. Yeah, just feel free to pop your questions in the Q&A tab. We'll take questions now. And there's a few coming in, but there was one for Lisa Jones. And I wanted to ask Lisa, what does cultural and spiritual abuse look like?
Yeah, sure. Great question. So cultural and spiritual abuse is where someone uses that again to maintain power and control. It can look like things like denying someone from practicing their beliefs or forcing certain beliefs on someone. It could also be using beliefs to justify or excuse violence. It could be preventing someone from connecting with country or doing any of the things, basically anything that the person would connect to spiritually or in a religious sense, using that as a form of controlling that person.
Yeah, thank you for that. Louise had to just hop off, so we won't be having her, but thank you anyway. There are a few questions because there's a few people tuning in from remote and regional WA. So I had a question for Rachel and Holly. Is your pilot project something that can translate well for regional and rural communities, and especially hospital settings in regional and rural WA?
I would say yes, very much so. So as Rachel mentioned, we have taken those pilot strategies, which, we sort of put a particular suite of strategies together, but they're nothing really new. We were sort of adapting those to our setting, but they're based on, a lot of those strategies are based on the global standards, and they will be applicable to any site. They might need a little bit of adaptation, but I think that a lot of the resources that we've created, and also some of the other health service providers, so North Metro, South Metro, and actually WA Country Health Service, there's a lot of those resources available. So if there's any rural, regional or remote people who would like some specific contacts, we can have a conversation, or we can refer them on to some of the WA Country Health Service sites as well. Yeah, but I think they can all be tailored well, and they have the same issue. I think all of these issues that East Metro and Royal Perth are experiencing, they really are statewide.
Yeah.
Rachel, do you have anything?
I would have said the exact same thing, but there is a website, the tobacco, the global network of tobacco health, smoke-free healthcare services. It's a mouthful, but we can provide the link in the chat, and that actually takes you through step by step the strategies for that are evidence-based and best practice, which we have based both the pilot and our further work on. So I'm happy to provide that link.
Yeah, that would be lovely. We do send follow-up emails to everyone, so they do get a copy of the slides and the webinar recording. So yeah, just reminding people of that. Holly, did you want to say something?
I was also just going to say that some of the resources, that the training resources, we have shared with other services. So if anyone actually would like to refer to some of those training resources, PowerPoint slides, or clinical lectures, so things like Dr. Kelly Ridley gave us a great clinical lecture putting in context around how we best support patients who smoke and their mental health patients or consumers. And so some of those resources are really, we can just send those links. So
yeah, that would be helpful. Kids Cot made some interesting comments, and that they're actually quite timely. So I just wanted to open it to all the speakers at the moment. She was curious if violence and abuse prevention programs are aware and addresses systemic trauma that's present and alive in many systems, programs, processes.
I can speak to our DV alert training for community frontline workers and say that one of the topics does include being trauma informed. It doesn't go into, there's some great training available out there in trauma informed practice, but we do cover the importance of it, particularly in the area of family and domestic violence. And on a number of levels, there can be trauma experiences that we want to make sure as services that we're not re-traumatizing someone, and that we are doing our best to work in that way. I think in general we're seeing more emphasis on working in trauma-informed ways as well, which is great to see.
Yeah, that's great. Holly, did you want to add to that? Or
I don't know. I mean, I don't know that I have a professional view on that, but I agree with what Lisa's mentioned, that it's really important if there's training to access that. And I think that a lot of our services are becoming more aware in general about how we can better meet the needs of our community and our consumers. And so I think just accessing that training and also speaking up when you can see that there's systems that can be improved. So I think, in terms of our health system, we look at really engaging with the community and also taking on board complaints and compliments. So I think that in terms of accessing training is a really good place to start.
thank you. And there's no more questions, so I'll just quickly wrap it up. Give me 2 seconds. So I just wanted to share that Injury Matters does have a few resources on our website. Oh, give me 2 seconds. On violence and assault, and there's a few resource kits and fact sheets for health professionals as well. So if you wanted to have a look at that, that's on our website under the No Injury tab. So yeah, feel free to go through that and see some stats around violence and WA. In terms of upcoming trainings and events, we have a few that are coming up. For next week as well, there's a webinar on what are we doing to prevent injury in the WA community. If any of these trainings on the screen interest you, feel free to hop onto our website and go through the events tab, and you can register to them. And there's a few coming up later this month as well, so we'd love to see you all there. And lastly, next steps on how you can keep the conversation going from today. We have the Injury Prevention Network. It's a network that meets quarterly to provide professionals such as yourselves an opportunity to collaborate and connect with other health professionals in the space and share learnings and solutions to injury prevention. So if you want to be a part of that, just flick me an email and I can add you to the list. When this webinar ends, there's also going to be an evaluation survey that pops up on your screen. I would appreciate it if you could please complete the survey so that we know what you thought about today's webinar, as well as any feedback you have about today's webinar or any future trainings as well. And lastly, Connected, which is our online networking program for professionals working in the injury prevention space. It is a networking program where participants are randomly paired to another health professional, and this is done every 2 months. And yeah, it's a great way to network with other people in the injury prevention and safety promotion space. As you can see, Michelle and Kristen met up over coffee and actually shared some great comments that they wanted to say about Connected program. So yeah, sign up for that if you're interested. There's a QR code on the screen as well. And that's it for today. Thank you so much, everyone. I am quite happy with how today went, and thank you all for the speakers. Really, truly appreciate your knowledge and your time for being part of this webinar. Thank you all for joining, and have a good day.
Thank you.
Thanks so much.
Thanks.
Thank you.